Today, all of the lines have been muted, and if you are experiencing technical difficulty, please use the chat for assistance or the help options within Zoom. Given the volume of virtual meetings and that our staff is all working remotely in separate locations, we apologize in advance for any network connectivity issues, and we will do our best to solve problems as they occur. We appreciate your flexibility. As a reminder, we hold monthly networking webinars on the second Tuesday of each month from 10 to 11 a.m. Previous recordings and upcoming webinars are all available on our website. If this is your first webinar, we hope to see your name in future months. And another quick update before we get started today is that we are excited to share that registration for the 2020 Virtual Wisconsin Cancer Summit is now open. We are taking this year's summit virtual, and we hope to see you all there. Over 2 days, the virtual 2020 Wisconsin Cancer Summit will bring together health system leaders, public health advocates, policymakers, researchers, and other partners from across our state who are working together to fight cancer. Together, we can build healthier communities for everyone by using the Wisconsin Cancer Plan as our blueprint for action. Register by October 1st to ensure you receive your summit packet in the mail in time for the event. Now let's go over today's agenda. First, we will hear from Dr. Tim Jessick and his presentation, Palliative Care Speed Dating, Why Palliative Care and Cancer Care Are Such a Great Match. At the end, we will have time for questions and discussions, and then we will wrap up. Now let's get into today's topic. I am pleased to introduce Dr. Jessick, today's speaker. Dr. Jessick has been a palliative care medicine physician for over 10 years. He is board certified in palliative care and family medicine. He is the co-founder and president of the Palliative Care Network of Wisconsin and a member of the American Academy of Hospice and Palliative Care Medicine and the American Academy of Family Physicians. Dr. Jessick received his Doctor of Osteopathy from Kirksville College of Osteopathic Medicine in 1994 and his Bachelor of Science in Exercise Physiology from the University of Wisconsin-Madison in 1990. He is a clinical adjunct assistant professor at the University of Wisconsin School of Medicine and Public Health. He has presented both locally and nationally on the topics of palliative care, pain management, advanced directives, and end-of-life care, and has participated in numerous initiatives related to these topics. Thank you so much for joining us today, Dr. Jessick. I will get your presentation pulled up and let you take it away.
Well, thank you very much, Alex, and thank you all for joining this this somewhat dreary morning. It's a great pleasure to be here and to work so closely with the Wisconsin Cancer Collaborative. And with you all, thank you for all the work that you do on a regular basis. And as I was listening to the bio and thinking about all those dates long time ago, it also reminds me of my previous work as a family practice doc. I generally say that I'm a recovering family physician. And I say that in jest just because, the primary care work, the working with folks in the clinics and so forth is such important work. And it's, thank goodness for folks that can do that on a regular basis. So today, as you heard, the title of the presentation is Palliative Care Speed Dating, Why Palliative Care and Cancer Care Are Such a Great Match. And as I was trying to think of an interesting title, this kind of came up for a couple of different reasons. One is that we have a lot of information to go over the next half hour or so. So bear with me as we talk about a lot. We'll definitely have some time at the end for your questions. But the other part is that, really palliative care and cancer do make a great match. We partner together very well. And that may not be very intuitive to begin with, but as we all know, taking care of our cancer patients is really about collaboration. It's really about partnership and how many different folks can we get involved with the interdisciplinary team to help patients out and their families. So this really is true and should be the case that palliative care and cancer care folks can and should be working together. then I got a little panicky about the title, thinking, well, speed dating, as I was thinking about it, is the old-fashioned in-person type of speed dating. And I thought, well, speed dating might be kind of the online type of stuff, or the ones on your phone too. And just be assured there'll be no swiping whatsoever today. Next slide, please, Alex. So really the objectives and the areas I really would like to cover today, and again, it's a lot of different things, is give you a better understanding of the role of palliative care providers, and especially how we as specialists care for complex cancer patients and what our role can be or could be for patients. But I really also want to talk a little bit about the difference between primary palliative care and specialty palliative care, and how that applies to you all. I'm excited to share some of the resources we have within the Palliative Care Network of Wisconsin website and group, which hopefully will be very helpful for everyone on the phone. And then at the end, discuss just briefly the impact of palliative care during COVID and what this meant for us and what this meant for our patients, our families, and all the providers. So for those folks that don't know much about palliative care, we're a newer specialty. We've been around 12, 15 years or so. So really newer when it comes to medicine in general. And we see and we take care of patients and their families that have serious, chronic, or life-limiting illnesses. So our role is really many. We get very much involved with pain and symptom management and symptom issues, but probably a big part of what we do is conversations. We really try to establish goals of care for patients and their families and their loved ones, and then really try to match up those goals with treatment options and try to match those up as much as possible. So what is palliative care? What's the special sauce, the secret sauce, right? And I'd love to say that, well, what palliative care is you have, I'm just such a great guy, and it's because of me that I make such a big difference, and it's all because of Tim. And as much as that'd be nice to say, it's really not me as a palliative specialist, but really our approach to care, I think. And when we do a consult, when we see patients, whether it be in the clinic, whether it be in the community, whether it be in the hospital or even in a hospice facility, it really is a structured approach. We have domains that we address and look at for every single patient. We look at pain and symptoms, and specifically the management of those. So pain and nausea and vomiting, constipation, anxiety, depression. And we're very diligent and very specific about asking and assessing these symptoms, what has been done for those symptoms and what can be done. We also focus on social and spiritual concerns. Who is the family unit for this patient or their extended family or friends? What did they do for work? When we're talking to a patient that was an engineer, our conversation may differ than when we're having a conversation with a farmer or with an artist or someone that has a different background. We want to know about who they are, what matters to them, what their culture is, how that affects the care that we're being provided. And then of course, any spiritual concerns or spiritual approaches or emphasis that they may have. A big part of what we do is really meeting patients and families where they are. Do our patients really understand the diagnosis that they have? If you have a patient that has stage 4 metastatic terminal cancer with probably a prognosis of less than 6 months, if we start the conversation and ask them what their understanding of their disease process is, and they reply, well, I have this little spot on my lung, I've been told, and I have this thing on my brain somewhere and so forth. But I think I can beat this. And I think that, my daughter's wedding in 3 years, I'm so looking forward to that. And this will be great. And these lumps aren't going to be a big deal. If that's the starting point of our conversation, it's going to be a longer conversation. So we need to make sure that our patients understand their illness, their prognosis, and the treatment options. Some of this may have been discussed in the past. It may not have been. Sometimes folks just don't understand what's going on. So our role is to really to help clarify some of that. And then from there, that's when we can start identifying goals and do some basic advanced care planning with our patients and families. We can't really talk about the goals till we have a better understanding of their understanding of the disease process. But what is a patient's goals or the family's goals for the patient? Is it staying alive at all costs? Is it focusing on comfort as much as possible? Is it to alleviate certain symptoms or certain problems? So part of what we need to do is identify those goals, start planning for the future, even though the current plan may be, let's do everything, including chemotherapy and radiation. But there may be some limits down the road. And then part of our role is really with the transitions. As folks, as their disease process gets worse, as they become weaker and need to transition from the home to a facility, or the cancer starts to progress and they need to go to the clinic for more tests and more evaluation. And if they get more sick and have to go to the emergency department and then get admitted to the hospital, how can we help ensure that the patient's goals are known, are shared with care providers, whether it be advanced care planning or goals of care? And then how do we as a system ensure that the care that's being provided for that patient is really concordant with their wishes? That's ultimately our goal and should be everyone's goal. So I would say what is palliative care? It's really this structured approach. But I would also ask, is this type of care limited only to fellowship trained palliative docs? Is this only limited to palliative trained social workers or nurses or palliative trained chaplains? And the answer is no. This is the secret sauce. Don't share it with anybody else. It's just for you all. This is very special. But no, it's not just for palliative providers. These are approaches that you all probably do to a degree on a regular basis and can and should do on a regular basis. And that's what we would call primary palliative care. And we'll talk about that in just a minute. So this is an older slide, but I love this slide. It kind of, in a cartoon feature, really shows you and demonstrates the continuum of care. So on the far left, you look at when a patient's diagnosed with, and in this case, let's say cancer. They're diagnosed with basic, very localized breast cancer. Well, the red shows that at that point, boy, majority of the care should be disease modifying therapy. What does this mean? What's possible? How can we get rid of this cancer, cure the cancer, and really help the patient out as much as possible? But at the very beginning, from a diagnosis perspective, can palliative care be involved? Absolutely. We can start with some basic advanced care planning, symptom management, planning for the future. But the need or the presence of palliative is quite a bit less than the disease modifying therapy aspect. As you move to the right and the cancer gets worse or the condition gets worse and the disease modifying therapy really becomes less and less, that's where palliative care really can be involved more and more. And again, palliative care means really the palliative care team, the palliative nurse, the palliative doc, the APC, the social worker, the chaplain. That's where our involvement really can have more of an impact with the patient. Now, as you notice, it's not a handoff. Okay, we're stopping disease modifying therapy and it's only palliative. That doesn't happen till the very end, right? This is where that collaboration, this is where that teamwork and that interdisciplinary teamwork between palliative care and the oncology team and the pulmonologist and the cardiologist and primary care is really, really important. But as time moves on and we get closer to death, which is far on the right, that's where palliative care can have more and more of an influence. The other data point on here, initially was diagnosis, next is 6 months. And that's the point where you really transition more from a palliative care approach to potentially a hospice approach. Then you see the other data point is being death and bereavement. So once a patient dies, this is where hospice still can be of benefit. The patient's died, but if the patient has been signed on hospice, the death and the bereavement part after death is super, super important for the remaining family members and friends. And that can go on for 12 months. So again, this is just a nice cartoon kind of illustrating when palliative care can be involved and kind of the impact over time. Some would argue that palliative care should be involved with the initial diagnosis of all cancers, all heart failure, all COPD. It sounds good. Honestly, we probably aren't needed as much early on. And to be honest, also, there's not nearly enough palliative providers to provide that care. So it sounds good, but it's probably not realistic. Sorry, Alex, for that last piece. And ultimately, our goal is really to make sure we match the goals of care that we have with to coordinate the patient's goals with the treatments that are possible. Ultimately, that's really going to be our key. Thank you. Next slide. So what do we do? Well, we really do target the sickest and most vulnerable patients. And as we saw over the last several months, we saw a lot of those sick, vulnerable patients. Even though our role really isn't to focus on the costless patients, that's not something we do. We don't look at insurances and so forth. Systems do. And just to know that as we try to promote palliative care and try to get buy-in for palliative care, not only from systems, from hospitals, from clinics, but also payers, we do help with cost. That's not the main reason why we do what we do, but there is an impact there, and that does help from a policy perspective. The other piece of what we do is really providing support for patients, right? For their family and their support system. We're not just there for that patient that has metastatic lung cancer. We're there with their family, with their friends, with their extended family. Part of our role is to include all of them because they're all part of that unit. But the one area that we probably don't think about as much is we're also there to help the caregivers. Not only the caregivers in the home and supporting them, but also the caregivers in the clinics, the caregivers in the hospital that are struggling, that now we have this 32-year-old woman with metastatic ovarian cancer. We know it's terminal. Boy, that bothers me as a bedside nurse, because that could be me, right? So that's part of our role, as well as to be aware of all those other folks that are caring for these patients on a regular basis. And then, as I mentioned, as far as transitions, how do we help folks as they transition, not only from their disease process worsening, but as they transition from one setting to the next. And when you think about all the touches we have with patients within the system, we first start seeing patients hopefully way upstream out in the community, where you start doing webinars like this, or talks, or advanced care planning sessions in the community, and breast cancer awareness month. We have a chance to really have outreach with folks in the community. And then as they start coming into the clinic, we get to see them there and have an impact and touch with them there. As they transition to the emergency department, it's another touch. Heaven forbid they get admitted to the hospital, another touch. Boy, they're too weak to go back home. Now all of a sudden they have to be transitioned to a long-term care facility or a subacute rehab facility. That's another area of care. And then at some point, if they do get transitioned to hospice, once again, another setting for this patient. So what we tend to forget is that within each of these settings are sometimes different providers. So as an old-fashioned family medicine doc as I am, I'm from the Marcus Welby age, right? Way back when, where we were the ones that delivered the babies and then took care of them as they got sicker and saw them in the clinic. We'd see them in the emergency department, admit them to the hospital, follow them through the nursing home and hospice, right? Well, healthcare is very siloed right now, and has been for some time. So you probably see a different clinician, different specialists in each of those settings that I mentioned. This adds to not really good handoff of care, but also there's also a lot of strange people that our poor patients and families are seeing. An emergency department doctor never met before, a hospitalist that's admitting them to the hospital, and so forth. So we just need to be aware of what patients are going through. So just briefly, so does palliative care help? The answer is yes. We know we help decrease length of stay in the ICU. Is this by denying patients care? Well, of course not. But if we can match up a patient's wishes and their goals with the potential treatment, all of a sudden a patient that does have metastatic lung cancer and is having a hard time breathing, if they realize that really their prognosis is quite poor, and that intubation may not be as helpful for them based on their goals, they may choose not to be intubated, or to be intubated but not for 2 weeks, but maybe just 2 days for a time-limited trial. So this can have an impact on length of stay in the ICU and even ICU admits. Again, clarifying goals of care with patients will help with readmissions. It'll help with folks going to the emergency department. If we can provide some comfort meds and symptom medication for folks in the home, they won't have to come back to the hospital for their shortness of breath. They won't have to get readmitted to the hospital with their aspiration pneumonia if that's not part of their plan. Cost avoidance wise, some studies have shown, well, multiple studies have shown the cost avoidance. One study in particular showed that a palliative care consult can result in savings of $3,500 per patient. Again, patients don't care about that, but systems and hospitals do. We can also help by identifying needs, what other referrals should be done? What other support does this patient need? Who else needs to be a part of the interdisciplinary team? Does it need to be home palliative care? Does it need to be a case manager? Does it have to be some sort of extra help in the home? So we can help coordinate that. As mentioned, we can provide support not only for the patients and families, but also the treatment team, for staff. When we provide support for these bedside nurses that are struggling with a patient dying, that does help with staff satisfaction and hopefully helps decrease burnout. But guess what? If we're helping with supporting staff, which then can help support patients and families more, patient satisfaction goes up. Not only do they have folks that are happy and willing to take care of these patients, they're also receiving care that really is concordant with their wishes. So just a little bit, I mentioned primary palliative care versus specialty palliative care. Well, what is primary palliative care, and who provides primary palliative care? Well, you all do. You all do this probably on a daily basis. And what am I talking about? Well, primary palliative care is provided by folks that aren't palliative specialists and who didn't go through fellowships. What does that mean? Well, you all are involved with identifying unmet needs, whether they be symptom needs, or boy, I'm falling a lot in the home, I might need some physical therapy. You do that on a regular basis. You also do basic conversations about diagnosis and breaking bad news. I'm sorry, Mrs. Smith, I have some bad news. Your CT scan came back with kind of a bad result. Pause. It looks like it looks like you have a lump in your lung, and it very well could be cancer. Let's talk a little bit about treatment options, but also prognosis. So again, you all do those type of things on a regular basis. Hopefully you all are looking for advanced care planning documents, starting advanced care planning way upstream, encouraging good conversations with patients and family about their wishes. Again, this is way upstream. And then hopefully completing advanced directive documents, power of attorney documents. So I usually use a story of, so heaven forbid, I'm on my way home from work and I get hit by a train. Well, nowadays, post-COVID, the story is, okay, so what if I'm at work in my office, in my house, and I go down the stairs and fall and hit my head, right? It's a different story. If I fall down, hit my head, and I'm unconscious, my wife's first response is going to be, get up, Tim, you fell down again. The next response is quit faking. And then after she figures out I'm not faking, she calls 911, sends me to the hospital. So if I'm unconscious in the hospital, and if I don't have a power of attorney document, if I don't have an advanced directive on file, who makes medical decisions for me? The answer is, without a document, it's consensus. It's not my wife automatically. It's not my family automatically. It's not my best friend. In the state of Wisconsin, we do not have a surrogacy law or a hierarchy law. So my wife isn't automatically my decision maker. And then my adult aged kids or siblings. This is why it's imperative in the state of Wisconsin that all of our cancer patients have good advanced care planning by trained facilitators, hopefully trained by Respecting Choices or some other course, and that all of our cancer patients greater than the age of 18 have advanced directives in their chart that not only designate their surrogate decision maker who can make decisions for me if I can't make my own decisions, but also some wishes. So super, super important. This is something that hopefully you all are doing on a regular basis. Also from primary palliative care perspective is basic code status discussions. You cannot start to have code status discussions if you did not talk about number 2. If you haven't talked to the patient about their diagnosis and their prognosis, and if they don't have a good understanding of what that all means, you can't even start to have a basic code status discussion, because it's imperative that you have the diagnosis and prognosis discussion first. But again, this is something you all do on a regular basis. And of course, you all are taking care of symptoms or referring folks that are having symptom issues. So this is what I would refer to as primary palliative care. Why is primary palliative care important? Well, number one is, there's not nearly enough palliative providers to do all of this for all patients. We're probably seeing only 5% of all the admissions to the hospital, and probably 20% of all admissions have some sort of unmet need, so we cannot see them all. So we really do need folks practicing primary palliative care on their own. So how is this different than specialty palliative care? So this is for folks like myself that may have should have probably gone through some sort of extra training, whether it be fellowship training, whether it's some extra schooling to do what we do on a regular basis and full time. As of 11 years ago, I do palliative medicine full time. And so what is it? What is that we do? What is that we add? Well, we can have ongoing discussions. Hopefully you all have had some basic primary palliative care discussions about basic goals of care. We can help with more complex goals of care discussions. If there is some conflict within the family as far as what to do or what not to do, we can help with that and sort through that. If there's conflict within the treatment team, maybe the oncologist says, boy, I think fourth line chemotherapy is the way to go. But the pulmonologist says, yeah, but their breathing is getting so much worse and it's really impacting their COPD that maybe we should look at different options. If there's conflict within the treatment team, we can help sort through that. And we can also help with refractory symptoms. And after you all have done some basic treatment of pain or nausea or anxiety, if it gets to be a little bit more complicated, we're very, very well adept and good at treating those symptoms. Again, hopefully you all had done some basic spiritual screening and social screening as far as where folks are. If it gets more complicated than that, if there are spiritual crisis, we can help with that. To be honest, if there's a spiritual crisis involved and I'm involved, that's where I call my local chaplain and say, help. But that's where you have a good interdisciplinary team that can help you out with different areas. Again, we can help with inconsistent goals. We get consults all the time where the provider will say, well, can you go see Mrs. Smith? She's in denial. She doesn't know what's going on, right? And we've learned to go talk to Mrs. Smith and first, say, what is your understanding about your stage 4 metastatic cancer? And if the response is, well, I have a lump in my lung, a lump in my head, as I mentioned earlier, well, maybe that it's not that the patient's in denial. Maybe the patient just truly doesn't understand what's going on. Maybe it hasn't been discussed or discussed well, or they're just not just not understanding what's going on. So we can help sort through some of those, some goals and some even more complicated goals. Again, we can help with family dynamics, especially the complex ones. We're not that good to fix family dynamics that have been going on for 30 years. I wish we could. I wish I could fix family dynamics within my own family, and I can't even do that. So it's going to be very difficult to do that on a greater scale, but we can help sort through some of those dynamics. And by understanding where some of those are coming from, sometimes we can avoid some of the landmines going on, especially with very complicated social issues. And then we can also have him very regularly are involved with challenging decisions, specifically at the end of life, specifically when we're talking about life prolonging treatments and trying to match up patients' goals with what can be. And honestly, it's not secret sauce. Sometimes it's just really meeting patients and family where they are. What is their understanding about the disease process? What is their understanding about what resuscitation can and can't do for you? What are the hopes and goals following treatment? And sometimes just spending some time sorting through their goals and what our treatments may or may not be able to do for them alleviates a lot of these issues. But that's where some of these life prolonging treatments and questions and then ultimate plans really will come up. So I think we've all seen, patient-centered care as a phrase. It's great on billboards. It's fantastic on little cards. It sounds, cozy and nice. And boy, that's what we want, is to provide, patient-centered care. That's what we do here at our system, at our hospital. And I'm not making light of it. It's just, what does that mean? What does patient and family-centered care really mean? What does that entail? How do we do this? And aren't we already doing this at our system? So to illustrate this, I've used this example in this case in the past. And the difference is, well, aren't we providing person-centered care? Isn't that what we're doing? And what's the opposite of that? Well, there's what I would call person-centered care or family-centered care versus clinician-centered care. And I'll say clinician to involve all of us, I guess. I think in general, we'd say that we provide a lot of clinician-centered care, very, very, very much maternalistic, paternalistic. And just briefly, the way I would look at this is as such. Let's say you have a 91-year-old woman who's living at an assisted living facility, gets around on her own, does very well, has a fall and hits her head. She gets transported to the local community hospital, where the emergency medicine doctor sees the patient, does the initial evaluation, then comes and talks to the granddaughter. A clinician-centered approach would be as such. Carol, I know you're the granddaughter. I just saw your grandma. Just so you know, she's stable right now, but I'm very concerned about her hitting her head. So normally what we do in a situation like this is, since she hit her head and there's a big brain bleed, we're very concerned about this. I'm very concerned about her breathing and her airway. What I like to do is go ahead and put a tube down her throat, intubate her. Because of the brain bleed, we probably should send her to a big old center that has neurosurgeons and so forth, where they could consider putting a hole in her brain, in her head, and drill and remove the blood from her brain, and then we can kind of see how she does. Does that make sense? And should we proceed with that? Okay, so don't all shake your head at once. The question here is this bad care? And I would suggest this care could save this patient's life. It could be very good aggressive care. It could really help the patient out. But then the next question is this the right care for the patient? And the answer is, we don't know. Why don't we know? Because we don't know what the patient's wishes are. We didn't look for advanced directives, and we really didn't give Carol, the granddaughter, much chance to talk. So a person-centered or family-centered approach may look more like this. Hi, Carol, I'm the emergency medicine doctor taking care of your grandma. As you know, unfortunately she fell and hit her head. It looks like she has a lot of bleeding going on in her brain, and this is a very critical situation. I'm so sorry to have this conversation. The good news right now is she's stable and she's comfortable. Before we start talking about treatment options, I need to know a little bit more about grandma. Have you two ever talked about what you would want or not want in a critical life and death situation like this? Has she ever discussed this with you in the past? Different approach. The outcomes might be the same, meaning that Carol might say, well, grandma wanted everything done no matter what. She staying alive for the sake of staying alive is most important to her. Of course you should intubate her, and of course you should send her to a center where she can have brain surgery. Or Carol may say, no, I've talked to grandma in the past, being in her garden, moving around and planting plants is what she really wants to do. Of course, I wouldn't want to stick a tube down her throat. And of course, I don't want to transfer her 30 miles away to another hospital. Could we watch to see how she does over the next couple of days, right? Different approach, different care. And that's how I would look at a person-centered approach versus clinician-centered approach. Just over the last couple of minutes, I just wanted to talk a little bit more specifically about palliative care and cancer care. And I think you've already heard or understand how this partnership really can help. For palliative care to be part of the cancer care team, we clearly can help with symptom management. We can help clarify goals of care, especially if there's some conflict going on. Hopefully the code status discussions and goals of care discussions have occurred prior to us getting involved, but we can help with those more complicated cases, of course. Of course, we can be involved more with advanced care planning, but really this partnership with the oncology team is critical because we can be very helpful for these patients and their families. The other piece is and what we've been currently doing a lot of is teaching primary palliative care. Well, what does that mean? We've really exerted an effort to train staff, hospitalists, oncologists, oncology team members, nurses, APCs, how to have these person-centered goals of care discussions. So to date, we've trained over 450 clinicians really statewide in how to have these discussions. Because folks aren't trained how to do this in general. Now, maybe more so than in the past, but to provide words and phrases that can be used to have these really, really difficult discussions is really a skill. I don't do surgeries and I don't do brain surgery as a skill, but communication is really our skill. And this is a learned skill that needs to be practiced over time. So part of what palliative care can do and Palliative Care Network of Wisconsin has done is really provided some of that training for clinicians on how to have these really tough discussions. So I've mentioned a little bit about the Palliative Care Network of Wisconsin. Again, just briefly, we're a grassroots network. We started about 5 years ago, and our hope was really to help provide education, systems change, a website, really to provide resources for folks that are taking care of sick patients, cancer patients, COPD patients. So this is really for administrators, social workers, nurses, chaplains, docs, nurses, whether in palliative care, hospice, or primary care, or oncology care. We wanted to have a place for folks to go to learn as much as they can about hiccups or goals of care discussions. I do have to make an admission to you all. So we finally came up with the name Palliative Care Network of Wisconsin. Being a true Wisconsinite, I was really pushing for the palliative care of Wisconsin. I thought that'd be wonderful in the state of Wisconsin to be referred to as PCOW. Still a little bitter that they wouldn't use my PCOW name. They thought that was not as a good name as Palliative Care Network of Wisconsin, but just saying. So just a little past history about us. We've been so pleased to not only have a fantastic website. Dr. David Weissman, who's really the guru in palliative care, not only created our initial website, but provided so many resources for folks. So if you go to mypcnow.org, the address is at the bottom. All the resources on the website are free. They're all for you. What started off as a grassroots network for Wisconsin folks has become a worldwide network, honestly, with over 5,200 members. So strongly encourage all folks to join. It's free. And all our resources, all our information on the website are for you to use, whether it be for goals of care discussions, symptom management, how do I pronounce somebody dead? How do I start a conversation? We've also so pleased to not only be involved with folks like Wisconsin Cancer Collaborative, but also working with Metastar and the Rural Palliative Care Project to be able to work with them, and also the Wisconsin Office of Rural Health. They're doing a lot of great work as far as rural palliative care, especially in northern Wisconsin and in eastern Wisconsin. So to be able to partner with them has been wonderful. And then doing advocacy work with not only promoting the Advanced Directive Registry, but also the State Palliative Care Committee and Registry as well. So that is part of our work. Just briefly, I'm not going to go through all this, some examples of how Palliative Care Network of Wisconsin can help oncology. Well, we have over 400 fast facts or down and dirty page and a half resources on everything palliative, everything symptom you can imagine, not only from a symptom management perspective, goals of care, but also code status discussions. Next slide, please. And just lastly, so how does palliative care, how have we been involved during COVID? It's been a trying time for everybody. I won't even go into how it's affected oncology patients in general. A couple of things really come to mind though, first and foremost. Number one is my personal opinion is that we really did fail our vulnerable patients, especially our elderly patients in the home, especially our elderly patients in nursing facilities. How did we fail them? Well, we could have done a much better job with earlier advanced care planning and advanced directive completion. I think we could have done a much better job as a whole, as systems and as leaders, to have more robust goals of care discussions with our patients. What ended up happening, what we saw is these poor patients got admitted to the hospital. They're scared literally for their life. And then they're in the hospital by themselves. For a long period of time, they didn't have their loved ones to be with them. So they're all by themselves. We had to really scramble to develop technology where we could, FaceTime or Google or Zoom with our patients. And I think we could have done a better job to prepare our patients. Part of what we did from a palliative care perspective is not only do some very quick goals of care discussions with folks, but we also did a lot of training. We trained a lot of case managers. We trained a lot of primary care clinicians on how to have these goals of care discussions proactively to hopefully talk to patients while they're still in the home about their goals, and does coming to the hospital make sense based on their advanced cancer and so forth. I think ultimately though, we were some of the few providers that did come back to the hospital early. That the heroes were truly the nurses and the respiratory therapists and the docs that were there from day one. But a lot of us palliative providers decided to come in, and the main reason was a lot of times we were the eyes and ears for families. A family member that's out of state or can't come in to see their loved one because of COVID wanted to know how their dad was doing. For us to be able to go in and say, yeah, I held dad's hand, and boy, he's kind of spunky today, and he really didn't like his oatmeal. But to say, yeah, we laid eyes on him and he looks good, and he kind of smirked and he kind of laughed, was very helpful for folks. So even just being the eyes and ears for families was a great piece that we could provide for these folks. And with that, I'll stop and answer any questions you may have. Thanks so much for your time.
Thank you so much, Dr. Jessick. That was really fantastic presentation, and I appreciated the PCOW acronym. Well, with that, I'll hand it over to our partnership member, or our partnership manager, Beth Brenner, who will facilitate a question and answer discussion now.
Great, thank you, Alex, and thank you, Dr. Jessick. That was absolutely unbelievable information, but more importantly, the work you're doing, especially through this pandemic. And I mean, it's touching to hear those stories of what you're doing day to day, but also, what you were doing to really help families that couldn't be there in person, to be those eyes and ears and to be that caring face for those individuals. So thank you for that. We do have some questions and a comment. So I will start off with the comment from Paul Westrick. Just said, the continuum diagram is essential for communicating and educating the essence of palliative care to all providers, patients, and families. So picture is worth 1,000 words. So thank you, Paul, for just sharing that. That was a helpful diagram, it sounds like. So thank you, Dr. Jessick. We do have a question here. Sometimes providers, in particular oncology providers, are reluctant to make a referral to palliative care. Do you have any suggestions on how to bridge this challenge?
Great question. And I wish I could say I've got it down perfectly and this is exactly what you do, right? So I think, I've learned over time that as much as we want to be person-centered and family-centered, and that's crucial, that's really, really important, we also need to be provider-centered. And meeting patients and families where they are is great, but we also need to meet providers where they are. And I've developed a new appreciation for oncologists, for cardiologists, and others. And I guess I will always assume good intent for whoever is treating patients, as we all should. But the appreciation with oncology, I've heard two oncologists in the last 20 years tell me basically the same thing. You know, as an oncologist, if I have a patient that I'm seeing that ultimately dies, I feel like I failed them. And it was I've heard this twice. And it's just sad to think that's where they are. And obviously could lead to burnout, right? But it also made me appreciate, you know, some folks are so dedicated to what they do, they really take it personally if they can't help a patient out. And you only have so many tools in your toolbox. So for oncologists, it's chemotherapy, it's radiation therapy, it's surgery, right? For cardiologists, it's procedures. So part of what we try to do is not only meet clinicians where they are, talk to oncologists, offer help wherever we can, but also ask them, hey, where do you struggle? What areas are really difficult for you, right? And developing those relationships are huge. Number one. Number two is, as Paul mentioned with that continuum diagram, it doesn't have to be all or nothing. It doesn't have to be, do you want chemo or not, right? It can be part of the continuum. And if we can involve ourselves or help the oncologist not to take over, not to start saying things, well, your oncologist is dumb, why are they offering fourth line chemo? But instead to really accent and help out the oncologist along the way while they're doing active treatment. All of a sudden we're a member of the team. All of a sudden it's not an all or nothing proposition. We can help make the oncologist look good, but ultimately help the patient and the family out along the way. Part of our role also is to very gently encourage, topics such as prognosis. You know, I went to a meeting with a gynecologist. We had a nice meeting ahead of time. He said that this patient's prognosis is poor, and we need to talk to the patient about her poor prognosis. By the time we went into the room and then left, he was offering more surgery, more chemotherapy. And I looked at him afterwards, I was like, what happened in there? And he says, yeah, I know. I think we could maybe try something else. And I said, well, would you be surprised if this patient dies in the next 12 months? And he said, no, not at all. I don't think she'll survive anywhere close to a year. And I said, well, don't you think the patient needs to know that? Shouldn't we discuss that? And he said, yeah, we should. We went back into the room and had a different conversation. So it's not a matter of challenging oncologists, but meeting them where they are, understanding what they're going through and what their thought processes are, and just trying to partner the best way that we can. And that can be difficult, but it takes a relationship.
Great, thank you. We do have another question, and I would say if anybody else has additional questions, please feel free to put them in the chat. We'll make sure to get to them today. One additional question we have from Dr. Noel LeConte asking, can you discuss optimal approaches, code discussion, and prognosis discussion over telemedicine? She finds it much more difficult in person than the in-person discussions.
Yeah, that's a super question. So these are difficult discussions anywhere, right? Anyway, doing it face to face, they can be tough. Doing it over telemedicine can also be tough. And one thing we found out nationally with COVID, and this is talking to our palliative colleagues, hospice colleagues, and so forth across the country, is that folks were so scared, to be able to reach out to our patients and families in their home and have conversations was very well received. There's some pushback when we started asking folks to do that because he said, oh, we're going to scare them and they're going to think that we're trying to write them off, or boy, we don't want them to come to the hospital. But the responses were completely the opposite. Oh, thank you for calling me. Thank you for reaching out to me and discussing my illness. Because yeah, I have been concerned about my COPD and my cancer. And what if I do get COVID or the flu? Do I even want to come into the hospital? So thank you, doctor, for having these discussions with me. So know first off that having these discussions for folks in the home, they love it because they get to talk to their doctor and it's something new and novel that we're talking to them or doing it via telemedicine. But also know these are questions that they have. And for us to address those questions are super important. So how do we do it over telemedicine? It's a little bit more difficult, or it's a lot more difficult for a lot of different reasons, but the approach is still the same. If our approach is not to have an agenda, not to get a code discussion or a no code order, and I'm not suggesting you're saying that, but if we go into this saying, listen, I want to discuss prognosis with my patient, I want to discuss treatment options, including procedures like resuscitation, and basically empower our patient based on their goals with treatments that will help or not help. If we go into that with that conversation or that thought process during the conversation, those conversations really can go quite well. So to first talk about, prognosis, I know you've been talking to a lot of your specialists, Mr. Jones, about your lung cancer and your COPD. What have you been told so far? I just want to make sure we're all on the same page, right? What else has everyone else said? And how are you feeling about this? And where is your mindset with all this? And then based on what they have to say, well, yeah, I have this bad cancer. I know that, and boy, the last thing I want to do is go into the hospital. And boy, I don't want to end up on a breathing machine. I've seen that on the news with COVID, and that's the last thing I want to do. You can get a lot of information from a patient as far as what's acceptable and not acceptable, which may lead to those code status discussions quite well. If they don't give us any hints, specifically code status, so their prognosis is poor because they're metastatic lung cancer or they're metastatic breast cancer but severe COPD. To be able to say, hey, listen, Mr. Jones, thank you for all that information. One thing we talk to all patients about is the extent and the aggressiveness of care. And this is something we ask about everybody too. We discuss and talk about with everybody, normalizing this, right? Heaven forbid something major happened where you had a massive heart attack or stroke and your heart stopped, you stopped breathing, and you died. What we would need to know as a medical team is whether or not you would want to be brought back from the dead by shocking your heart, doing chest compressions, and putting you on a breathing machine. Have you ever had those conversations with your family in the past? Pause. We're not telling them to be a full code. We're not saying be a no code. We're not saying you should be scared to death. This is going to happen today. Have you had those discussions, right? Now the patient may say, well, why do you ask? And you're scaring me. And do you think that's going to happen? That's where we put on our clinician hat and say, well, I don't think it's going to happen today. We just want to make sure we're providing the right care for you. And if you don't think being on a breathing machine or going through resuscitation is something you'd want to do because it's too aggressive, and oh, by the way, because of your metastatic cancer, because of your severe COPD, I do not think resuscitation would bring you back from the dead. I don't think I would recommend it as your clinician, right? There might be a way to discuss code status and resuscitation without it being scary initially, but to be honest and saying, listen, I don't think it's going to be successful. And honestly, I'm afraid if we did all those things, you'd end up in the ICU, and we did resuscitate you, you'd be on a breathing machine by yourself. That's my fear for you. What do you think? Empowering patients so they have a voice and what care they want or don't want is very important. Now, on the flip side, if they said, I want everything done, heck yeah, you better jump on my chest and bring me back from the dead. And yes, I know my risk for coming back is very low, but living is the most important thing to me. And I feel based on my faith, I have to go through all that. Great. Then you have the discussion, you document your discussion, make sure everyone else knows what the plan is.
Great, thank you so much. And just there has been comments on just thank you and great suggestions for the thoughts you'd provided on the questions. So thank you, Dr. Jessick. Do we have any other questions or comments or thoughts for Dr. Jessick? Otherwise, I'm going to turn it back over to Alex to close out the presentation.
Thank you, Beth. And thank you all for attending today. And thank you again, Dr. Jessick, for speaking on this. It was really a great presentation. And before we close out today, just a quick reminder for next month's webinar. It will take place on October 8th from 10 to 11. And this October's topic will be putting the plan into action. So how can we put the new Wisconsin Cancer Plan 2020-2030 into action? Share your input on our October webinar and help the Wisconsin Cancer Collaborative decide how to prioritize action areas within the new Wisconsin Cancer Plan 2020-2030. You can register for that now by following the link at the bottom. And we also hope to see you for our November webinar on November 12th. This topic is still to be determined, but we will have more on that soon. Thank you again for attending today, and we hope to see you next month. Have a great day.